We go on to the last speaker for the session, the cochlear implant session. I don't think she needs any introduction, right? Is there anyone who doesn't know her? Please raise your hands. Dr. Sampurna Ghosh, who's the chair. She looks very pretty today.
I've only known her as a student. Now she's a master.
Yes, she's a big lady now. So, gold medal from Calcutta, cochlear implant surgery, OS-day surgery, academic inclination, a learner of new techniques, invited speaker, surgical faculty and panelists in many national and international academic forums. I'm sure we'll be seeing her many, many, many more times in the future. Sampurna, the floor is yours.
Good afternoon, everybody. Long sessions and discussions going on. From basic otology to advanced otology, we are moving. I thought to talk on how to venture into cochlear implant because it is a dream for many otologists. So what is the expectation versus reality? I'm going to talk on that topic now. Today started the Olympics in Paris, and we are doing this like mini Olympics for ENT surgeons. 400 delegates from all over country, and Southeast Asia is not a joke. It is a really something like Olympic for us. Once more, welcome to the city, which has the blend of the old historical places as well as the beautiful high-tech city where you are sitting in. And I always feel proud to show my picture with my mentors, Professor Somnath Saha, Dr. Srinivas Kishore, and Professor J.M. Hans. And you can see Hans sir's guru, Dr. Trifon, is also there in the picture. And I'm also grateful to Dr. Janardhan Rao Jagini, who has helped me to learn the posterior tympanotomy, and whenever I am in some trouble, I do take his help as well. And I recently had training from Professor Robert Briggs in Sydney as well. So what is the learning curve of CI? So I just thought that what I have seen that there are two ways people learn. Some people are there who after master degree will go for fellowship, or which is definitely the best way, but everybody's journey is different, especially for ladies. If you are a mother, if you have a family, if somebody have a transferable job, there are people who go to their mentor for short multiple teaching courses and then start on their own, how I did mine. And of course, there are lucky people who during their MS or GNB in their own institute get a good exposure of the CI techniques. They are very well versed with the post-op protocols, pre-op investigations and all. But there is pros and cons of both these groups. Those who are exposed in early stage, once they learn during the MS, but the time they reach to a level when their practice is established, even a CI candidate will consider them to be trustable enough to do CI for their child. There may be a long gap, so they have to be in constant touch of the technique and keep practicing that. And they have to do, because the early exposure, they have to keep doing cadaver dissection. They can also practice in the artificial bone model. The other group, exposure during practice, that is like you can visit to the mentor's place multiple times. You can have your mentor to your center, like how I have been very lucky that Hans sir agreed to come for all my initial cases from Delhi to Hyderabad. So you have to select the proper person who will not only just give you a fellowship certificate, but actually will catch your hand to take you to the level when you are independently able to do it. And keep on going, learn and implement, learn and implement. Don't think I will learn this completely, then I will do the first case. There is nothing such in any of the surgical subspecialty. You have to learn, you have to do and layer up your knowledge as you keep doing. How easy it is to start CI practice? So again, government setup and private setup, two different approach. Government setup, of course, you need the approval and you need to set up a nice team. Whereas in private practice, it is quite difficult to start. It needs persistent efforts. It is not enough just to learn the technique. You have to be very, very passionate to start. It will take a lot of effort. There have to be a long-term plan and vision, otherwise it will not run smoothly. You cannot have in the first year itself 10-15 patients who will come to you for CI. It will start with 2-3 and then gradually it will increase, but you have to have that patience and passion still there to search for patient to continue your journey of learning. You must build a team of audiologists and AVT therapists, and you have to search for different free schemes, NGOs, if you really want to continue this. Equipment is an issue in both the setup, especially in India, but outside countries also. So whether it is government, you have to wait that I need this, and in private also you have to ensure them that I am able to revenue generate enough that you will invest this for me. But if you are not able to do that, my suggestion is always invest in your equipment. Buy it, start doing it, the rest of it will keep coming. My reason of starting with Varia was two. One, I immediately loved the technique when I saw Hans sir doing it in the first place. And second, I told him, sir, I do not even have Zeiss microscope. At that time, I was operating with Opto. And Opto is quite good, by the way. They have their stall. I'm not diminishing them. But I said, sir, I have an Opto microscope. I have a marathon drill. I don't have Medtronics drill. I don't have nerve monitor. So do you think this is doable? He said, no, better. With a loop also you can do. Go ahead. So with minimum equipment can be started, and later on you can upgrade your equipments. When can you start a CI clinic? You have to first build a very, very good general ENT practice. Like Prepa sir beautifully answered my question and bowled me out about the pituitary, why you want to ruin your peace of mind. So basically your routine septoplasty, tympanoplasty, tonsil, adenoid, these are our bread and butter. Once you establish that practice so well that your name is well known and people trust you, then only CI patient will come. Nobody can directly live on just doing CI if somebody has not done 3000 like Hans sir. So people like us have to respect our regular ENT practice and live on that, and these are only bonus. These are to enjoy, not for money. Navigating the market. This I don't know how much applicable for Malaysia, but for India that was really, really tough. Cochlear implant, I think like stents in cardiology or knee implant in orthopedic, this is the only thing which is very costly the ENT surgeons deal with. So there is a lot of business model and politics and monopoly which you have to go through, but if you have the wish, it can be done. How to navigate the market? You have to know about different company products yourself very well. Ask your mentors, ask the audiologist, don't get completely biased by what the company people are teaching you. As a surgeon, you should take the upper hand, you should learn the science and technology so that you can decide and not being, completely driven by the company people. At the same time, you have to make friendship with them, because these are the people who will train your audiologist. Your audiologist may not know anything about CI, they will give training, they will come for initial mapping, they will come to your OT, so there should be a nice balance maintaining your self-dignity. How you may feel initially? I think everybody knows this series. So Game of the Thrones, everybody is behind getting the thrones. So initially this feeling may come when a new CI surgeon has started to do, but it will not persist. We can grow together. How? Be open-minded. Learn all the techniques. You may love one particular technique, but don't be biased that the person who is doing PT is bad or the person who is doing Varia doesn't know anything. You should know both the techniques, because there are situations when you may like to do the other technique, so you can deal with all the complicated cases, and you have to learn from your audiology team and AVT also. Don't think that you are the superior most person. No, without a team, you are nothing. Your job is only to put the implant. Rest all will be taken care of them. The patient will be more in touch with the AVT team and the audiologist. And most important, don't hesitate to call the mentors, because initially when I started, I used to get simple cases like normal cochlea, good thickness of nerve, but as your number increases, then only you start getting the anomalous cochlea, thin nerve, different syndromic child. So don't think, okay, I have seen that somewhere, I will manage it. No, feel free to call your own mentor. If he or she is not available, make connection with the local CI surgeons who can help you, and definitely if you tell somebody, sir or madam, I need your help in OT, they will come down. By doing that, you will be in a safe zone. Slowly you will start navigating through the difficult cases, and you will have the confidence of giving the good result. So the situation from Game of the Thrones can change to this. Whoever have watched this may understand how the situation changed for Sachiv ji once he came to that remote village versus once he was leaving from it. Let us simplify. We ENT surgeons from the MBBS MS, we are used to see this graph more than beta. That is the truth. We are more see PTA. We don't see so much beta. So to remember that when the PTA graph is showing a loss in this red area, that is more than 70%, then you think about CI. Don't think that it is 80, 90. Below 70, start thinking of CI. About pediatric criteria, everybody knows. Okay, in the MS question comes, but what I have seen, I was not taught about adult CI candidacy much in my training period, and presently also among the audiologists and among general ENT practitioners, this is very hazy area. People don't talk much about the adult candidacy. That is why I have put this. And you see from 1985 to 2019 how the criteria has changed, how they have become more lucid now and their guard has come down. At time it was only bilateral profound loss. From there it came down to severe to profound. Then it came down to moderate to profound. And now we are doing single-sided deafness as well. These are the common criterias. And coming to candidacy, I always say that think beyond the audiogram. Audiogram does not give the whole scenario. Audiogram gives you an idea about sound perception, but sound sensation perception are different. You have to look into the speech discrimination score. You have to ask your patient about clarity. Are you able to understand what you are watching in the TV, what you are speaking in the phone? Are you missing the sound? Many times they can say, I'm able to hear, but I'm not able to understand. We don't give much attention to these kind of things. We simply write hearing aid trial. After going to the trial, what happens? We sometimes don't track them. But it is mandatory that after hearing aid trial, the patient should come back to you and then you evaluate all these things. If you see there is less speech discrimination, less clarity, and the hearing is deteriorating on the lane, then you counsel that probably you need CI. Immediately the patient may not have the budget, may not be ready, but at the end of 1 or 2 years, they will think about it that the life doesn't end here. I'm not getting benefit, so there is another option. They will come back to you for CI. This is the 60-60 guideline which was formed to guide the American audiologists when to send the adult candidates for CI, where they have said that if the PTA average is more than 60 decibel, in better ear, 500, 1K and 2K Hz, and if the unaided word recognition score is less than 60%, you can consider the candidate for CI. They will not benefit much with single hearing aids. There are different kind of other implants as well. Tomorrow there is a talk on this, and Dr. Sanjay Sachdeva is going to talk on Baha, and Shailaja from Medal will speak on all these devices. So please do attend that. Audiological assessment you all know, start with BERA, OAE. ASSR rarely I do, impedance I definitely do, like tomorrow's case has been admitted and today we repeated the impedance because anytime they can develop glue ear. Role of OAE, OAE is a screening tool, so if BERA is not showing any peak, you look into the OAE. OAE absent means you should be happy as a CI surgeon that yes, I can give a good result. The problem is in cochlear outer hair cell. OAE is present mean doubtful, it is ANSD. Will you not recommend CI? Of course you will recommend CI because there is no other tool available to give them hearing, but you will have a guarded prognosis. You will spend more time counseling the patient along with your audiology team. These are the radiological assessment, and even though we read all these chapters during the MS, but that is only for exam preparation. If you don't really do that after just 2-3 years, then because I get the calls that madam so and so patient is there, what scan we will write? It's very simple. Just go for a CT temporal bone and a MRI, look for the nerve and look for the cochlear overall anatomy. These are the radiology specification. This is how a normal cochlea should look. This is a 3D image. If you have this, good, but if you don't have, a simple CT or MRI will be sufficient also. You have to identify simple things like labyrinthitis ossificans, and you have to set your eyes to identify normal versus anomalous inner ear. This side is normal, this side is anomalous. Early implant is the main thing nowadays that developed countries are doing implant less than 1 year age. We are little behind that because our neonatal hearing screening is not yet universal. Varia technique will be shown tomorrow, so I am not showing any video here. Similarly, PT video also I will skip. Candidacy for difficult cases. Can we do for MR autism? Yes. Can we do in common cavity? Yes. Can we do in Mondinis? Yes. All these cases CI can be done and good result comes. Only again you have to explain the parents what to expect and what not to expect, how much the speech will come. Definitely child will hear because the technology is simple and CI is one of the most reliable implant in the medical science. So you have to assure them at the same time give a realistic picture. Inner ear malformation. Previously when I started going to different CI workshops, when I thought may I learn this, I used to hear so much talk about this, which literally demotivated me. Classifications, these, that, but probably this is not so much important because not all cochlea are anomalous, or small percentage of cochlea is anomalous. And if you don't remember those classification, it's okay. You can start your journey. While doing, you will learn again. Candidacy for difficult cases, ANSD, yes, can be done. Simultaneous versus sequential, very important. If your budget, patient has adequate budget, child is fit for surgery, you are confident that you can finish on time, then go for simultaneous bilateral CI. Postlingual candidates give excellent result because they are already exposed to sound. These are different kind of audio processor, implant. Slowly you can learn that. One more minute, sir. How do you select implant? This is another thing the beginner will stumble. Which implant I will give? Should I give Cochlear? Should I give Medal? Should I give AB? Again in Cochlear there are so many classification. Medal has so many nomenclature. Just look into the reliability. Every company will have that data in their website. And talk about the MRI compatibility. These two are the main things. Expectation versus outcome. This is a balance game in CI. Don't give a dreamy picture to a child who has come to you at 5 years age without any auditory stimulation before. Don't tell them, yeah, after doing within 1 year the child will go to normal school. You have to tell them earlier the implant, better is the outcome. So should I venture into the new domain? Of course. If you have the passion, you are passionate enough, your thought process will manifest and you will convert into that particular domain. You will be a regular CI surgeon if you really want. These are some of the pictures of my patients who are from different states of the country and different countries as well. And luckily I have the experience of doing from 1 year old to adults. And this is how the journey is going on. Thank you all. The main reason of selecting this topic today was, I asked Dindayal sir before coming, sir, how many ENT surgeons are there in India? Probably 12,000 you said. 12,000 ENT surgeons in India. We have a group called CG, only 800 members. And that in 800, 400 are audiologists. So in 12,000 ENT surgeons, 400 CI surgeon. Is CI surgery so difficult? Not at all. Just you need right mentor, right setup, and we need more CI surgeon because by 2050, the number of deafness will increase and Southeast Asia is the hub of congenital hearing loss. So we should not keep the knowledge within ourselves. There should not be monopoly. I expect that you all who wants to learn, select your own mentor and start into the venture. Thank you all.